update. And I knew that this program is happening just about an hour ago. I had given 2 sessions like this before. The last one was more than a year ago. So they're struggling to find out that slides. And it's not easy because we may be in different places, right? So if you can bear with me, I will be speaking to you without any visual aid. So it will be mainly purely audio. Is that right? Okay. We are not giving excuses. Okay. Just to advise the situation, because when you come, you must have certain expectation. And this topic is on medical posting. It must be, and it has to be one of the most important posting when you start your housemanship, right? So for me to stand here without a properly prepared material and then address you, it is a gross injustice to not just this program only, but the actual medical posting itself. Okay, so but put that aside, and if you understand and you can accept that, call it an excuse if you want to, then I will proceed. Is that all right? Okay. So just to know again, because I didn't have much time for the briefing, you are supposed to start your housemanship, or you have started already? So you are supposed to start housemanship. And you all, I assume, must have come from different background from your medical training with regard to your medical school colleges. How many are from local graduate? And that will be from various universities, and some are from overseas, right? How many are from Russian Republic? Ada tak? Crimea ke Russia? Tak ada. Now this is not pointing to, Russia is better, KL, Malaysia is worse, It's just to get some idea on who you are, because I don't know what had been presented so far this morning, but you all probably appreciate that there are various medical programs having different curriculum, different emphasis. Some may be traditional, some may be integrated, some may start clinical years right from the beginning, some may actually be traditional year 4 onward. So with that, there may be different level of exposure with regard to knowledge and clinical cases, as well as management at the level of medical student. So that's important for us to understand, because when you come, you work as a team. And the team now in hospital, sorry again, I have to keep saying this, sorry, because short of Bidang Terjun, I do not want to repeat things that you had said, you had heard already. You had lecture so far this morning? So this is the first lecture? Okay, so I can assume that you don't know anything. I pretend that you don't know anything, but of course you know something. To pass the exam, you had to know a lot of things. So when you report to Malaysian hospital to start housemanship, there are only designated hospital that can train housemen. Housemanship is part of the formality for you to get a full registration as a medical officer. Medical practitioner, registered medical practitioner, is one of the profession that is governed by law, ethical standard, professional standard. So like many other professionals, we had to register ourselves to practice, to get license. As a houseman, you will get temporary practice as a houseman before you get full registration with the Medical Council, Malaysian Medical Council. Right? Once you complete your housemanship, then you become medical officer. And for many years now, housemanship in Malaysia take 2 years to complete. In my time, in the 80s, before that also, it's only 1 year. So now 2 years, right? So you have to go for 2 years, you complete your housemanship, and then you become medical officer. And the rotation also changed. Previously, the compulsory one were medical, surgery, medicine, surgery, obstetric, gynecology, orthopedic, pediatrics. And now there are extra modules to cater for the reality that there are so many housemen coming out from the factories. So these are emergency department, anesthesia, and lately they had added the community medicine module, right? So you had to rotate through this, and there is a formal assessment, logbook and formal hard black and white assessment, and some form of direct assessment, either backside or interview, viva, for the different module. So it's a serious business. So you have to go through all that, pass, then you go to the next. If you don't pass, the system allow the mentor, the supervisor, to actually delay your next posting. Maknanya you kena penalty, and you can be penalized for a few months up to 6 months. So then you had to actually go through this assessment again, satisfy the supervisor requirement, then move on to the next. Because of that, there were many housemen who did not pass as planned. That they start and they finish everything by 2 years. Because ada sangkut in between. They did not pass. So instead of finishing 2 years, 2.5 years they have not finished. The intake as houseman is decided by the public service department for the public sector. And housemanship, ada jumpa? Ada. Housemanship is not done in any private hospital. I think 38 or nearly 40 hospitals now are all government hospital, either Ministry of Health, majority, or Ministry of Higher Education, University. University Malaya, USM, those with the University Hospital, UKM. The other hospital don't have. Like UPM, they share with Sedang Hospital. So you had to do housemanship in those hospitals. The hospital requires certain standard to be gazetted as a housemanship training hospital. They must have the number of cases to be seen, the number of facilities, the number of specialists. When they certify all that, and then they also have the in-house continuing medical education program for ongoing training and teaching. When they have that requirement, then they will be gazetted as a houseman training hospital. So you go to that hospital after getting the posting by the public service department. Okay? And public service department conduct an interview and take people in, housemen in, based on post created by Public Service Commission. Public Service Commission will then advertise. So then there is limited number of posts. Because in order to have posts, you need to have a place to work. You need to have salary waiting to pay. Right? And housemanship, even though it's the lowest rank among the medical professionals, it's not cheap. In my time, my salary, starting salary, was 1,300 ringgit. So if I tell you now, you as houseman, we had to start working for 36 hours per week, on call stretch for 1,300, you will say you will just become jaga kereta. That's better, right? But nevertheless, the few thousand ringgit per month that you will receive as a pay, even though maybe meager compared to some other profession, will have to come out from the taxpayers. So the finance minister had to budget, and they table the budget. Like for example, in October every year, finance minister table a budget at Parliament. Ministry of Education berapa billion, Ministry of Health berapa billion, Ministry of Defence berapa billion. So they channel that budget, including the payment for emolument, including for housemen. Right? Jadi jumlah jawatan tu terhad disebabkan oleh had budget. Dan juga had hospital. Bukan semua hospital. Ministry of Health ada lebih kurang 140 plus hospital. Ministry of Education maybe 5 more hospital. So about 150 hospital total, public hospital. But only about 40 or so for housemanship training. Right? Jadi terhad nombor facility, terhad bajet untuk membayar gaji. Jadi yang ada sekarang 5,000 pos. Setahun. Tapi houseman 2 tahun. 5,000 masuk tahun ini. Dah habis tahun pertama, lulus semua, masuk tahun kedua. Yang baru nak start, masuk tahun pertama. Yang tahun kedua dah habis, keluar jadi medical officer, get posted. Mana-mana, Tawau, Sabah, Sandakan, Lahad Datu, Kuala, Pilah, wherever. Tapi yang masalahnya, yang first year, sangkut. Yang second year, sangkut. So, apa jadi? Bila sangkut, katakanlah 5,000, at one time, 30% sangkut. 5,000 sangkut berapa? 30%, 1,500. First year sangkut 1,500. Second year 1,500, jadi 3,000. 3,000. 1,500 tak boleh nak keluar, sangkut. Jadi 1,500 kat sini, tak boleh masuk, sangkut. 1,500 kat sini, tak boleh, tak pas, tak boleh masuk situ. Yang ni tak masuk lagi, tak boleh masuk, sangkut. Jadi 3,000. So because of that, many of the newcomers like you all had to queue. And the queue takes time. I'm not giving excuses, I'm just telling you the reality out there. Kemudiannya semua dah beres, you masuk housemanship. And you get posting. Cuma masalahnya, bila nak sampai posting, masa training dia buat dekat Crimea, nothing going to Crimea. Masa posting houseman training, medical training, dia buat kat Yogyakarta. Dia dekat Makassar, dia dekat mana-mana je lah. 5 tahun, ada mungkin sampai 6 tahun kalau dia buat pre-U. Bila dah dapat houseman posting, dia diarah pergi ke hospital Kuala Terengganu. Masa itulah juga dia menangis, tak berhenti-henti. Sebab dia nak duduk dekat mak dia. Ayah dia sakit. Isteri dia mengandung. Kucing dia sakit. Masa dia belajar kat luar negara 5 tahun, tak ada masalah. Masa nak buat posting, tiba-tiba kucing dia sakit ataupun dia tak boleh tahan. Tahun 2 tahun. Jadi banyak orang yang appeal. Jadi orang faham, satu tempatnya dah terhad. Yang keduanya ramai lagi nak masuk. Yang kita dah dapat ni pula. Nak pilih pula nak pergi kat mana. Itu yang dah houseman. Lepas tu dah habis houseman 2 tahun, kena posting. Keluar. Yang dah duduk dekat Kuala Lumpur, tak nak bergerak nak duduk kat Kuala Lumpur juga. Sebab datuk dia sakit, nenek dia sakit kat Damansara. Jadi macam itulah. Jadi ini realitinya. But if you understand that you are coming as part of the apprentice in the youngest part, the lowest part of the apprentice scheme, to move up the ladder. You had spent 5 years in medicine. I started my housemanship in 1984. 2 years A-level, 5 years medicine. Alhamdulillah tak pay apa-apa. Some, like Dr. Suhaimi, Dr. Ishak, maybe a few more years longer. So that's a long years. But we are still talking, I'm still talking to you. And many of the things that I talked to you were not there 30 years ago. So that means I had to acquire knowledge and skill. And on, there will be program, like for example, in 2 weeks' time, I'll be going to Korea, so to attend a transplant meeting, where I'll be chairing session, maybe I'll be talking also. But as I talk, as I listen, also I listen to the rest, who speak on the latest. So meaning, the training, the teaching, the learning is continuous. It's a lifelong process. So you had completed 5 years, you masuk housemanship, to start your apprentice as a clinical doctor. Maybe if you want to be clinician, some of you may not end up as clinician. What we're doing for this is medical postings, making you aware about what is there in medicine, what is there in hospital that relate to the medical practice. But even if you don't like medicine, or you find medicine unbearable, too tough, too demanding, you like ONG because you like the sound of a crying baby that come out from a pregnant woman, and then they will hug and kiss you because you know this is the first child, very emotional, very happy moment, right? But on the day you heard that your consultant is sued, Or on the day that you heard that the premium for insurance in the private sector for ONG, certain discipline is very high, many thousand per year, become prohibitive, then you rasa, takut. So there are some good thing about a discipline, another bad thing about another discipline. So you go to that process, medicine, ONG, surgery, pediatric, orthopedic, all that, to try not only to put into practice what you learn in your medical school as a medical student, come to the front as a frontline officer. Because now, you are no longer standing behind your tutor, your final year medical student, your registrar. You are there at the front. Kalau teruk lagi dekat emergency department, kalau posting dekat emergency department, masa saya first day, kes saya kat Hospital Kuala Pinang, apa dia? Report very eager nak berbakti pada nusa bangsa dan negara. Okey, berjihad fardu ain pula, fardu kifayah. Right? Mari dia kampung nak tolong ibu bapa, semangat kan? Kes first saya buat surgical posting dari Pulau Pinang. First case masuk daripada ED dah transfer ke ward, kita kat ward tunggu. Kepala pecah, tulang terbuka. Darah merata. Macam mana? Dekat medical school, you pernah ke buat macam tu? You are the first officer nak handle. Tak terkejut? Terkejut. Right? So, tapi if you already had interest, you already willing to face challenges, then you take that as a challenge. But you know that you are not alone. You got many people behind you. Your medical officers. And then you get registrar, senior medical officer. And then you have specialist. And then you had consultant. Then you had senior consultant. Then you had department. 5, 6, 7. Kalau you pergi dekat swasta lain, dia tak ada housemanship. Ada medical officer, tapi medical officer usually is only on limited basis. Biasanya straight specialist. Sebab whatever encounter and service given will go to the pocket of the service provider. Jadi kalau orang lain tengok, you tak dapat duit. Alright? That's why we pergi ke hospital swasta, specialist je sana. Ada specialist tu je, 10 tahun pun specialist tu jaga. Kalau hospital kerajaan, you pergi tengok, hari ni doktor ni, besok doktor lain. Kalau ward round, minggu ni doktor ni, minggu depan doktor lain. Right? Because the process and the service is different. In the government sector, it is not just service but training. In the private sector, it is mainly service, no training. Right? But wherever it is, bila you dah go through that posting, medical posting you tengok, apa macam mana. Surgical posting macam mana, ONG macam mana, pediatric. Then you come up with certain idea about the reality of clinical services out there. But dulu, you pergi kat ward, macam saya nephrology, mungkin your tutor pergi, okay, go and see that lady ward to be bed 30, a case of leg swelling. I want you to go and take history, examine, and then present to me. But when you were a husband, alright, it's not leg swelling that come. The patient who come with, acidotic breathing, fluid overload, severe hypertension, stroke, right? You may not have exposure for that case. Atau you may have, but it's only on theoretical thing. Ataupun masa duduk dalam tutorial classroom here, you are at the back, hoping not to be asked any question. But here now, not only that the patient is asking for your help, but the patient is in emergency and actually hoping, and the family around them, hoping you to save their life. And you are the front line. So the reality is different. Jadi bila you tak tengok posting yang lain-lain tu, your exposure, your transfer of knowledge from your theoretical days in medical school to the practice out there will be defective. You cannot put there, dekat luar, slogan poster, sakit gigi, gigi rahang. Bukan, not a dentist. Kita letak situ. Gigi itu saja. Orang lain jangan mari sini. Dia buka hospital, demam kepialu sahaja. Dia tak boleh macam tu. Semua bagi. Dan ramai orang kat luar, dia ingat tiap-tiap doktor ni tahu semua. Dan kalau pergi ke klinik pakar, dia ingat semua yang kerja kat klinik pakar tu doktor pakar. So expectation. Now expectation sekarang ni lagi hebat. Sebab sebelum mari, dia dah ada Google. Sebelum mari, dia dah ada anak, dia ada adik-beradik, dia dah ada waris dia, dia ada kawan dia yang doktor, yang nurse, yang profesor. Jadi dia have certain knowledge already, certain expectation. Jadi bila dia mari kat you cannot say, sorry saya tak tahu. Memang you tak tahu pun. Tapi there is an art of doing it. Alright? You tak boleh, bila orang sakit mari, you menangis. Saya pernah dengar houseman masa balik kerja, buka kereta dengan radio, ada radio call, the anchor take in callers, apa masalah nak cakap, alright, dah berbincang berkenaan dengan hospital dan masalah berkaitan hospital. Jadi ada orang tu telefon. Yang masa saya dengar tu, seorang perempuan telefon. Dia cakap masalah dia. Lepas tu yang anchor person ni tanya, saya tak ingat adik ke puan dia tanya. Katalah puan, puan ni kerja apa? Saya doktor. Jadi doktor yang telefon radio memberitahu masalah dia sebagai doktor. Bukan masalah dia sebagai doktor nak nolong sakit, tapi dia sendiri ada masalah. Dia tertekan, dia tak boleh nak buat tu, tak boleh buat ni. Macam mana gitu? Kita duduk kat depan tu, orang mari nak minta tolong, berhajat untuk mendapat perawatan. Ingat kita ada ramuan, ada kebaikan untuk tolong dia. Kita sendiri jadi masalah. Tak boleh lah. So, you need to actually build confidence, acquire as much knowledge as possible, and acquire as much skill as possible. Lepas pada tu, you dah ada habis housemanship, you pergi round-round semua, you make up your mind. You nak jadi surgeon ke? You nak jadi physician ke? You nak jadi pediatrician ke? ONG specialist ke? Orthopedic surgeon ke? Ataupun, aku tak boleh tahan kerja hospital. Tak boleh balik, tak boleh mandi, tak boleh makan. Lepas tu kalau mengandung 8 bulan pun jalan lagi kat keliling walk koridor. Kalau macam SKL tu macam satu bandar, daripada satu tempat. Okey? SKL ada 12,000 staff. Ada berapa? Dekat almost 1,000 doctors. Several hundred doctors. Sampai pengarah hospital pun ada doktor tak kenal. Besarnya macam tu. So imagine you pregnant, you jalan sana jalan sini, letih. Jadi tak tahan. Lepas tu mari orang pula maki hamu, marah, tekan. Bos pula marah. Okay? Lepas tu unfriendly, not cooperative, not helpful. Tak boleh tahan. So tak nak kerja klinikal. Jadi ada option. Pergi ke non-clinical tapi mesti hospital based. Jadi orthopedic radiologist. Duduk kat belakang tengok CT scan, ultrasound, MRI. But now even radiologist pun become clinically orientated. Dia panggil intervention radiologist. Dulu tengok saja, oh ada cyst. Oh ada query tumor. Tapi sekarang ni certain radiologist had developed skill with training, with facility. Dia boleh masuk instrumen, suck out fluid, hantar sampel. Yang patutnya yang cara biasa kena buka open process. Open process. Now they can do percutaneous. Dulu nak buat prosedur memang kena buat surgery. Sekarang banyak prosedur boleh buat percutaneous, image guided by CT scan, ultrasound, MRI. Macam saya dekat nephrology dialysis, kita kena masuk tube untuk dialysis, banyak tak boleh sebab orat sini dah block, orat sini sempit. Dia orang boleh cannulate with special image intensifier, masuk dalam, masuk stand, buat dilate. Boleh. Certain condition like stroke, hemorrhage, AB malformation rupture, dulu kena buat operation, buka craniotomy, cari vessel abnormality, clip, suture. Sekarang ni trained intervention radiologist can put in the wire, guide wire all the way up, put in a coil ataupun gel and embolize and thrombose the clot ataupun the bleeding vessel. So those are innovation and new thing that happen. Tapi kalau yang tak nak buat tu, dia tak nak cakap dengan patient, dia tak boleh cakap dengan patient, dia tak rasa tak selesa dengan patient. Dia jadi intervention radiologist, duduk tengok image saja, buat report. Itu satu. Yang satu lagi pathologist. Sebab dia memang minat nak buat medicine. Macam saya ada seorang trainee nak buat nephrology, 3 years specialty training. After dah dapat general internal medicine, kena buat 3 years lagi subspecialty training. She was very good. Lepas tu ada masalah dengan suami. Yang tak kahwin lagi, bukan saya kata jangan kahwin. Tapi ya, bila kita dah jadi isteri, dah jadi ibu, jadi doktor, macam-macam cabaran dia. Jadi banyak sangat tugas, banyak sangat kerja, tak boleh nak tahan. Suami bebel, suami ke, so you have to choose your family ke your profession. Jadi dia berhenti training. Dia ambil lighter clinical training, dermatology. Right? Boleh juga. Tapi itu pun mungkin tak boleh tahan juga. Jadi ambil patologi. Duduk dalam lab, tengok specimen, tengok slide, report. Okey? Tak payah on call malam, tak payah mari hari Sabtu Ahad, tak payah mari kerja masa hari raya. Doktor juga, doktor patologi. Dan patologi pun ada subspecialty dia. Right? Dan ada yang kerja di luar hospital. Primary healthcare, community medicine. Memang klinik lepas pukul 5 tutup. Hari Sabtu Ahad tak ada. Macam kalau pergi ke SKL, klinik kesihatan Kuala Lumpur dan Jalan Fletcher tu buka. Sebab ramai sangat orang, menteri minta buka. Dia sepatutnya buka pukul 9 malam, pukul 5 dia dah tutup. Alright? Sebab banyak hal lah. Tapi kebanyakan klinik pukul 5 tutup. Hari yang kerja. Tapi sebenarnya mereka kena faham bahawa tugas mereka sebagai community health medicine specialist, dia panggil family medicine specialist kan. Macam for you who have been trained in UK, you not sure ada siapa yang train kat UK? Tak ada. Dia ada panggil family doctor, general practitioner that has got a set of patient in the community under their care. You are supposed to see them for any of your health need. If you need to be hospitalized, the doctor will refer you to the hospital. If you don't go, they will call you at time because they get payment for your encounter. For vaccination, for antenatal check, semua sekali they will manage. Alright? Kat kita tak ada. Yang general practitioner buka klinik berkata, kat Chowkir, Jalan Ipoh, berkata-kata tu. Itu MBBS, MD, lepas habis, housemanship, setahun kerja, 2 tahun MO, dia dah dapat posting berkata dia tahu macam mana nak diagnose some skin problem, some medical problem, dia buka klinik. Majority, one of the profession yang dasar ekonomi baru berjaya menghasilkan ramai bumi putera orang Islam adalah medicine. We target 30%. So we have achieved that. But many of the graduate that come out from UKN sekali tu, dia jadi general practitioner. I'm not saying that GP is not good. GP is important because they are again the frontline healthcare gatekeeper before the patient is referred to hospital. You tak boleh pergi ke hospital nak jumpa specialist straight dekat government hospital. Kalau macam tu habis. Satu specialist kurang. Yang keduanya facility dalam hospital sendiri untuk specialist tu bekerja kurang. Macam saya kata tadi, intervention radiologist. Kalau dia bekerja dekat hospital Kuala Kerai, dia tak boleh buat apa-apa sebab facility tak ada kat situ walaupun dia train. Jadi kalau orang semua boleh pergi terus kat specialist tu untuk dapat treatment, kacau lah. Right? Walaupun tak perlu pergi. So dia kena ada filter. Jadi yang filter ni, the front line, GP dekat community, medical officer dekat poliklinik, semua tu. Right? Jadi dia akan decide, kes ni perlu di refer atau tidak. Tapi kalau dia tak tahu apa satu yang masa posting medicine dengan surgery, dengan ONG ni, semua kes di refer ke hospital lah. Kacau macam tu. Right? Hospital pula jadi crowded. I'm not sure whether you have brought any of your relatives, loved one to hospital. And if you go to hospital, especially to the specialist clinic, you can see ramai patient. Ramai. Some of the referral may be indicated, some may not be indicated. Tapi kalau orang yang gatekeeper ni, yang jadi medical officer lepas habis houseman training ni, get good exposure, good training, good advice on what to do, on basic in each discipline, then the gatekeeper function of the generalist ni will be good. Jadi hospital pun tak crowded sangat. That's number one. Number two, many of the diseases that afflict modern life, modern community, including us, we are low middle income country now, going up to the high income country, hopefully the next few years. We are faced with explosion of what they call non-communicable diseases, NCDs. Diabetes, hypertension, obesity, alright, cancers, chronic kidney diseases, millions. And the number is increasing in terms of rate, percentage. Diabetes, for example, dulu 12%, lepas tu jadi 15%, 17.5%, 20%, 22.5% of prevalent rate among adult population in the country. Like, for example, in my case, kidney diseases. The prevalence for dialysis before mid-90s was less than 50 per million population, Malaysian population. And now, the prevalence of dialysis patient is 1,300 per million population. Dialysis is end-stage kidney failure, you all know. Maybe the numbers increase because the facility increased, the budget for dialysis increased, maybe. But if you look at the causes of kidney failure, diabetes, hypertension, related to that obesity, that prevalence also increased. And not only it increased, it increases by affecting population that were not traditionally the risk factor before. Type 2 diabetes, for example, affect what? What age population? Type 2 diabetes. Budak-budak, kanak-kanak. Dewasa, adult. Adult onset. Terminologi dulu. Adult tu, baliklah kan. 20 tahun lebih kat atas lah. Biasanya 30, 40, 50. Sekarang ni diabetes affect, type 2 affect teenagers. Apa hal dengan sebab ada CT scan? Apa hal sebab ada mesin dialisis? Nothing to do with that. Right? It's a change of lifestyle. Yang mari kat hospital, heart attack, stroke, kidney failure, itu dah teruk. Yang tak teruk lagi kat luar. For example, if I take chronic kidney disease, for example, you know chronic kidney disease has got 5 stages. 1, 2, 3, 4, 5. Dulu dia panggil chronic renal failure, chronic renal impairment, end-stage renal disease, all various sort of non-standardized terminology. Kan, there is a standardized way of classification, chronic kidney disease 1 to 5. Yang dialysis tadi, stage 5. Estimated GFR less than 7 ml per minute. Kalau ikut pada prevalence study adult population in Malaysia we did 2012, there were, for stage 5, there was 0.36% of the Malaysian adult population. Calculate lah, Malaysian population now about 32 million. Right? Total dialysis patient and stage GFR less than 7, 40,000 total. Okay? That is, as I told you, 1,300 per million population. Right? Tapi if you go into stage 1, 2, 3, 4 total kali, there were about 9% of Malaysian public. Jadi maknanya yang base kat bawah ni, yang belum teruk lagi tu lebih ramai lagi yang teruk. Sebab yang dah teruk tu dah mati lebih awal. Tak sampai hospital, mari hospital pun lambat diagnose ataupun lambat rawat ataupun tak nak rawat. Jadi yang base ni ramai. Sama juga hypertension, diabetes yang dapat stroke masuk hospital. Bukan maknanya hari tu baru darah tinggi. Sebelum pada tu dah darah tinggi. Were they diagnosed? There was this rule of health for hypertension for any standard diseases. In the community, how many percent has got that condition? Hypertension. Out of 1 million Malaysians, how many percent has got hypertension? That's a question. Out of the hypertension, how many knows they have hypertension? Aware. And then, from those who are aware, how many are treated? And then, for those who are treated, how many achieve treatment target? Like, for example, you know the definition of hypertension is? What's the normal blood pressure? 120/80. What is the definition of hypertension? More than 140/90. That's hypertension. Right? Tapi, is hypertensive patient aware of their disease? Macam mana kita nak aware? Is hypertension a symptomatic disease? No. Tapi ini juga kita sebagai doktor, bila kita tanya sakit ambil history, patient tu ada hypertension, mari hospital, blood pressure 200 over 120. Makcik ada sakit kepala tak? Dia pernah dengar tak orang tanya soalan macam tu? Tak. Dia tanya sakit, ada sakit kepala tak? Abang ada sakit kepala tak? Jadi, satunya, orang sakit tu kata, saya tak ada. Tak pernah sakit apa-apa. Tapi pernah dia tak cerita dah, dia dah jumpa doktor dulu, dia pergi nak check medical insurance ke, dia sesama ke tinggi, tapi dia tak nak cerita, doktor dah diagnose, dia tak makan ubat. Dia malu atau dia takut doktor marah. Tapi kalau betul pun memang dia tak tahu, tapi sebab doktor tu tanya, you ada sakit kepala tidak? Orang yang duduk sebelah dia tu pernah dengar dulu, darah tinggi ni kalau kau tinggi ada sakit kepala. Ataupun dia tak pernah dengar, tapi sebab dia dengar doktor tu tanya ada sakit kepala, dia dapat impression hypertension ni sakit kepala. Jadi sebab tak ada sakit kepala, tak ada darah tinggi. Boleh tak darah tinggi jadi sakit kepala? Saya boleh melarat ni sampai pukul 5 petang ni. Sampai masa dia tunjuk tangan ya. Berhenti. Right? Boleh tak darah tinggi sakit kepala? Boleh? In what condition? When you have very severe hypertension with complication. Complication apa? You get hypertensive encephalopathy, you get cerebral edema, you may get nausea, vomiting, sakit kepala. You tengok dalam mata, apa nampak? Papilla edema. Okay? Bukan ni blood pressure 200 over 100, dia suka tengok F1 petang ni. Dia tak sakit kepala. Kalau tak ada cerebral edema, tak ada. Apa lagi? Sakit kepala, hypertension. It very complication of hemorrhage. Right? You can get hemorrhagic stroke. You can get ischemic thrombotic stroke. Kalau thrombotic stroke, dia senyap. Dia tak cakap. Tapi hemorrhage, sakit kepala. Right? Apa lagi? Any hypertension that present with symptom that include headache. Hypertension. Hypertension, majoritinya sebab apa? Hypertension is a bread butter medicine kan. You masuk orthopedic, you tengok fracture, you nak buat operation, you tak tengok blood pressure, you minta anesthetic bagi blood gas, anesthetic bagi, doktor, blood pressure dia 220 lah. I can't get gas. Oh sorry my job is only to look at the femur. Tak boleh cakap macam tu. Obstetric ke apa ke semua, you kena tengok. Right? So, what condition present with hypertension with symptom? Tadi kita kata hypertension with complication. They present with headache. Apa dia? Orang tu kepala dia besar, dagu dia sini, tangan dia besar, you tak jawab lagi, dia rasa nak tampar you. Lepas tu you tunggu lagi, kaki dia makin besar, dia rasa nak sepak you. Lepas tu dah dia tak tahan sangat, lidah dia makin besar keluar. Apa dia? Hyperthyroidism. Baik. PT3, tumor. You tak pernah tengok acromegaly. Pergilah buka buku lah. Okey. Tumor dalam. Okey. Acromegaly. Satu lagi, apa dia? Endocrine tumor. Fio. Palpitation, sweating, headache. Right? Ada lagi apa? Cushing. Okey. Tapi are those the common causes of hypertension? What are the common causes of hypertension? Asymptomatic. Memang tu dah tangkap asymptomatic hypertension. Sebab dalam vocabulary dia, sorry lah, bukan main je. dalam vocabulary dia kan, hypertension ni symptomatic. Sebab tu doktor tanya tadi, sakit kepala tu tak? But you are saying that in most of hypertension, there's no headache. Because most of the hypertension is essential, primary. Some people call idiopathic. Kan? We keep repeating this story. The doctor is an idiot, the patient is pathetic. Right? Sebab tak tahu diagnosis, pergi jumpa doktor, tak tahu penyakit apa. Dan masalah orang kita ni, kalau dia doktor tu cakap tak ada sebab, orang sakit ni memang rasa sakit, dia percayalah makhluk halus tu. Dia kena sebut tu, kena sebut ni. Jadi penting untuk kita bila kita cakap kepada pasien, kita dah investigate, saya tak jumpa perkara-perkara yang serius. Mungkin betul lah, saya bukan kata puan tak sakit ke apa, kita tak boleh rasa, tapi puan rasa sakit betul lah. Tapi tidak ada sakit-sakit yang bahaya, yang biasa-biasa boleh menyebabkan. Okey, yang dia mari tu, satunya dia nak tahu ada penyakit ke tidak, yang keduanya dia risau, takut ada penyakit-penyakit lain sebab kawan dia mati sakit tu, adik-beradik dia mati sakit tu, dia risau. Right? Jadi bila dia main kat you, dia kata, saya dah check you tak ada penyakit lah. Itu yang masalah, dia pergi kat lain, dia nak cari penyakit. Dan ada satu gerai kat situ, dekat coket tu, yang boleh cari penyakit. Dengan pegang ujung jari. Itulah hebat. Jadi, the patient did not fail, you fail. You fail to take proper history, do proper examination, and then talk to patient. Majority of hypertension are essential. Tak ada simptom. Tapi sebab kita tanya patient ada sakit kepala tidak, dia memberi gambaran pada sakit bahawa darah tinggi ini sakit kepala. Right? But you know that only in certain condition with hypertension present with headache or develop headache as a complication. Bukan presentation of hypertension, bukan symptom of hypertension. You must know. Kan kita dah belajar medical school, sign, symptom. Sign is what you see, what you detect, what you feel, what you can detect on examination. Symptom is what patient present, tell you. Tapi ini pun satu hal juga. Symptom ni depend on not only what the patient tell you, but what also you ask. Kalau you mari kat situ, sebelum mari kat situ dengan phone ni, macam cakap apa? Nanti sekejap, petang ni saya lewat sikit. Dia nak cerita apa? Dia dah tengok doktor ni bersibuk. Satu nak mari kat hospital, nak jumpa doktor tu, bila dah berdebah dia tak nak. Mari pula, sebelum masuk dalam bilik doktor tu, nurse kat luar bertengkar sana, bertengking sini semua sekali. Lepas tu mari seorang pakcik tu lah mengamuk, tambak sangat semua sekali. Jadi dia pun dah gelabah. Masuk dalam bilik doktor, doktor tak tengok muka dia. Macam mana dia nak dapat good history? Contact tu, eye contact tu. Cuma reality lah. Saya nak beli doktor semua pun tak boleh juga sebab macam kat Islam mungkin dia tak ramai sangat patient tu. Pun ramai juga. Tapi kalau pergi ke hospital tertentu tu ada beratus patient. Sebelum pada doktor pergi ke klinik tu, dia dah pergi kat ward. Dah ward penuh patient. Lepas tu ongkos pula malam. Habis pagi, lepas tu nak pergi kat klinik. Sebelum masuk bilik doktor ada puluh-puluh orang kat luar. Dia pun dah pening kepala. Jadi kalau boleh dia nak habiskan cerita dia cepat-cepat. Tapi that is the fundamental of medical practice. If you don't get proper history, you are not going to get the symptom described properly. If you don't get the symptom, you have problem in deciding how to examine the patient. Kalau patient tak cakap dia sakit kepala, takkanlah you... saya berlakon lah sikit. Alright? Ni, katakanlah dia ni orang sakit mari jumpa saya. Dia tak sampai sakit kepala. Dia sakit sendi. Takkan saya pun pergi cek kepala dia. Right? Kalau dia komplain sakit sendi, saya akan cek sakit sendi. Tapi dia tak cerita mana lain. Dia tak cerita sebab dia ingat dia tu lain tu tak related. Tapi kita tak tanya. Right? Ataupun kita tak dapatkan information daripada orang yang datang sebab orang yang datang tu tak boleh cakap. Orang yang cakap sakit sendi tu bukan orang sakit, anak dia. Right? Kadang-kadang macam kita dalam multiracial punya country, kalau mari yang Indian patient yang tua-tua ataupun Chinese patient yang tua-tua tak boleh cakap bahasa Melayu, bahasa Inggeris, kita nak cakap macam mana? Jadi cakap dengan anak dia. Right? Jadi orang sakit tak cakap. Jadi yang cakap ni orang yang interpret complain orang sakit tu. Maknanya kita assume dia punya knowledge about the patient complaint tu betul. May not be. So you need to get good history to proceed to the next. Mana boleh kita senyap di situ? Okay? Buat ultrasound abdomen. Mesti kena cakap dengan patient dulu. Yang you belajar dekat medical school, presenting complaint. But patient mari, mesti dia komplain. Takkan saya saja mari, kenapa? Saya nak jumpa doktor. Ada macam yang UK model tu, kata tadi kan, kalau you tak mari jumpa kat doktor, dia 6 bulan sekali akan panggil mari. We appreciate your kind visit to us because we realize from the system you had not done, you had not seen us for several months already. So dia hantar kad untuk jemput you datang balik. Sebab bila you datang balik tu, as part of the package dia dapat payment. Jadi bila mari, sebab aku mari, sebab doktor panggil. Dekat Malaysia tak ada macam tu. Right? Kita pergi kat doktor dengan ada komplain. Jadi apa masalah makcik? Makcik tak ada masalah. Lepas tu masalah apa? Anak suruh mari. Lepas tu kita tengok anak dia. Pasal apa? Tak, saya mari tengok mak saya buat letih je. Okay? Makcik tak ada problem. Anak dia tengok mak dia letih. Tadi, then you had to build the dialogue. Mudahnya. Nak tahu sama ada letih tu significant atau letih tu merupakan masalah. Which you had to decide what investigation to proceed. Right? Jadi, dia ada presenting complaint. Tetapi, biasalah. Orang yang datang komplain ni, dia history, cara orang Malaysia cakap pun dia susah. Dia katakanlah, apa sakit? Sakit kepala. Atau apa sakit? Sakit dada. Apa sakit? Demam. So you build the next question. Berapa lama, how long, where, what precipitate, what relief, all that. Okay? Jadi masalah dekat Malaysia ni, satu, sama ada kita ada masa, ada minat, ada knowledge nak build up a good history. Yang keduanya, orang yang cerita ni sama ada they have a good way of describing. Masalah kita, orang kita ni, kita tak kerti cakap, kurang cakap. Macam you all, lepas ni kita tanya, ada tak soalan? Kalau ada 50 angkat tangan, saya rasa yang buat program ni kena bagi hadiah khusus. Orang, 2 orang kat. Kita sendiri ni pun, yang boleh cakap, ada knowledge, ada macam-macam, tak cakap. What do you expect patient mari kat sini dengan doktor nak cakap? Jadi, kalau you tak tahu macam mana nak dapat good history, memang susah lah. But if you don't get good history, you don't get the reason for the problem for the presentation, macam mana you nak proceed? Sakit. Demam. Yalah. Berapa hari? Itu saya cerita biasa. Sakit, sakit dah lama. Lama mana? Sejak masa anak saya kecil lagi. Anak kecil, yang berapa? Anak yang 3. Dah? Mana saya tahu anak yang berapa? Yang 3 lahir bila? Kan? Tapi jawapan dia tu dia tak berapa clear. Jadi kita ni nak kejar masa. Makcik sakit berapa hari? Seminggu ke, sebulan ke, 7 hari? Jadi kita kena bagi direct kat dia. Tapi you tak boleh straight daripada awal-awal direct question. Makcik sakit apa? Sakit kepala. Berapa? 2-3 hari dah sakit? Ya. Jadi sebab kita direct, kita put word in the mouth. Dia dapat kita pun tulis tu, headache 2-3 days. Tapi sebenarnya dia bukan 2-3 hari. Memang yang sakit ni 2-3 hari. Tapi sakit dia dah berbulan-bulan. Right? Tapi sebab kita cara macam-macam, sebab kita tak sabar ke, kita nak cepat ke apa, sakit kepala. Ada 2-3 hari dah. 2-3 hari. Ya. Jadi tak 2-3 hari. So that one will impact on subsequent way you develop your case. Sebab 2-3 hari itu banding dengan somebody we headache for 2 years, is it different? Orang tu sakit 2-3 tahun, 4-5 tahun, banding dengan orang yang sakit 2-3 hari, yang mana yang serius? 2-3 tahun serius? 2-3 hari serius? Okay? Both can be correct. 2-3 hari pun serius, 2-3 tahun pun serius. Tapi kalau 2-3 tahun sakit, depending on how you proceed with your history and examination. Kalau 2-3 tahun you tanya lah benda-benda lain, nak tahu sama ada sakit ni signifikan atau tidak. Tumor, vomiting, raised intracranial pressure, any localizing sign. Takkanlah 2-3 tahun sakit, kepala ada meningioma, ada astrocytoma kat situ, duduk je kat situ, saya baru balik cuti dari Caribbean minggu lepas. Okay?
anak saya ni yang keempat ni nak dapat PhD kat sini. So bulan depan saya nak pergi. Takkanlah 2-3 tahun ada brain tumor macam tu. Tak ada masalah lain. Right? Tapi orang tu tak pernah sakit. Tiba-tiba sakit kuat. Sakit kepala. Belum pada ni pun tak tahu sakit kepala macam mana. Sekarang sakit kepala kuat. Dan you take symptom, ada benda lain. Ada visual changes, ada localizing sign, ada symptom to suggest raised intracranial pressure, nausea, vomiting. That's significant. Tapi yang 2-3 tahun tadi pun, mungkin juga significant. Sebab disease evolve slowly. Dulu tak ada masalah loya muntah. Sekarang ada loya muntah. Dulu tak ada lemah kebas. Sekarang ada lemah kebas. Maknanya the disease was there for a long time, but it has progressed. But it depends on what you ask. Tapi, tak payah tanya lah, senang. Order CT scan je lah. The problem for you is, when you see that patient, you are in klinik kesihatan Lahad Datu. Bukan di hospital Kuala Lumpur ataupun hospital Selayang. Jadi nak order CT scan macam mana? So you bagi Panadol. Balik rumah. Diagnosis, headache, query cause. Examination tak ada apa tak ada. Malam sekarang patient balik, sawan. Besok, baru sempat, malam tu, malam aku satu pagi sebelum sampai hospital, you tengok, ataupun kawan you tengok, patient tu dah dilated pupil. Right? Mati, buat postmortem. Tengok ada tumor kat dalam. Anak dia rupanya tengah buat PhD ataupun buat fellowship in neurology dekat Queen Square, London. Tak sempat balik. Balik, ambil cerita. Dalam cerita tu, bila buat inquiry, ada hospital inquiry. Saya bukan nak takutkan you all. Nak cakap reality. Buat hospital inquiry, internal inquiry, external inquiry. Kalau lah dapat lawyer lagi, pergi jumpa ICU in court. Ada tumor kat dalam. Diagnosis buka dalam, query cause. Tapi no further plan. Tak ada nak buat arrangement for CT scan ke, nak refer to neurosurgery, neurology dekat hospital Queen Elizabeth ke, tak ada. Tak apa, cik, abang rasa tak ada apa-apa ni. Okey, balik pergi Panadol. Tak ada plan. Sepatutnya kita boleh beritahu kalau ada masalah apa-apa, datang hospital balik. Saya nak buat ni tapi alat ni tak ada, tapi kita akan cuba arrange. Ataupun doktor pakar nak mari daripada sana minggu depan. Kita bagi appointment minggu depan. Maknanya ada plan. Ada plan. Sebab you punya assessment history examination tadi, you had come up with a differential diagnosis. Faham tak? So is other thing like dengue. Now dengue is a viral syndrome, right? Demam. And it's quite common. We are endemic country. Kalau pergi kat medical ward tu penuh dengue. Kalau setengah-setengah hospital ada dengue ward. Dengue ward. Kiri kanan atas bawah dengue je. Right? Sebab banyak kes. And not only banyak kes, tapi the natural history of dengue now has changed. I'm not in medicine. But this is from the general knowledge. And also the fact that we work in hospital that many dengue. Dulu dengue, majority okey, tak ada masalah. Dulu dengue 3-4 hari positif baru IgM. Lepas tu platelet dia semua low, semua white cell low semua sekali. Lepas tu manage, stable okey. Sekarang ni they come explosive. Collect, severe hepatitis, shock, hemorrhage. Tak ada nak cakap. Right? Tapi there are certain clue. You ask. When you think history, somebody had fever, you want to find out whether this is, what are the causes of fever? Cakap je lah. Tak bukan loteri pun hari ni. Tak ada cabutan tua. Apa dia? Infection, general. When you manage cases, there are general things for you to go through. Infection, malignancy, metabolic, genetic, autoimmune, drug, general. Okay? So fever, infection, drug pula, bakteria, virus, fungus, right? Infection. Lagi apa lagi? Tengok tadi saya cakap infection, malignancy. Malignancy boleh jadi fever? Boleh. Right? Hematological fever, tumor, solid tumor, boleh. Sama ada direct as a tumor ataupun as as a complication of that tumor, immune compromised state. Apa lagi? Metabolic condition boleh jadi fever. Boleh? Well, ada certain condition patient complain fever. Apa masalah bang? Saya demam. Biar 5 minit lagi. Okey. Demam. So it's not fever. Demam ni patient rasa simptom. Dia rasa dia demam. Nurse check 37. Kenapa? Boleh tak jadi macam tu? Boleh. Tapi kalau tak check temperature tak. Demam, fever 3 days. Rasa body ache sekali, bagi Panadol. Mungkin bagi erythromycin ke apa, viral fever. Fever is what they feel, dia rasa panas. Patient with thyrotoxicosis, hyperthyroidism, high metabolic rate, dia rasa panas. Dia tak tahan panas. Right? Patient with anemia, significant anemia, dia rasa macam demam, tapi dia bukan panas, dia rasa sejuk. Orang demam, panas satu, sejuk. Macam demam juga. Kenapa orang anemia boleh jadi demam? Dia komplain demam. Dan you rasa dia macam demam. You dah cerita tu, fever, dia tinggal 3 minit lagi. Dia tak ada fever. When there is anemia, the response to anemia is what? By the body physiology, you baca physiology. What happened to the vessel? Vessel dilate. What happened to the heart? Tachycardia. When your vessel dilate, you lose your core body temperature. Or your temperature from the central core is released to the peripherally vasodilated vessel. You lose your core temperature. So you feel sejuk. Lepas tu you rasa patient, oh yelah panas lah. Panas. Yang jenis yang penyakit cardiologi tulis. Tak check pun tulis. Tipu. Okay? Dia tak demam, tapi dia rasa panas. Kenapa? Vasodilatation. Your central heat core temperature tu is brought forward to the peripheral skin. You lose heat. You feel cold. You tak fever. Dia tak demam. Metabolic. Certain condition, kalau yang pergi kat Mekah, 40 degree, 43 degree ambient temperature, temperature tinggi sangat, your enzyme, your hormone breakdown, your temperature control breakdown, then temperature naik. Jadi heat exhaustion, lepas tu jadi heat stroke. Metabolic. Apa lagi? Drug. Boleh jadi drug fever. Drug response, drug reaction, allergic reaction boleh jadi drug fever. Autoimmune disease boleh jadi fever. Apa dia contoh? SLE. Jadi maknanya you dah ada information knowledge ni, you nak buat differential diagnosis, you kena tanya dia. You nak tahu SLE ada tidak, you tanya simptom SLE. Ada tak joint pain, ada tak rash, ada tak alopecia, ada tak oral ulcer. You nak tahu ada drug induced fever, you tanya ada tak makan ubat tu, ubat ni semua sekali. Right? That's something also maybe I can share with you, the history and the drug tadi tu. Macam umpamanya, for me, in nephrology, one of the important thing that we want to find out when we take history is when patient had got kidney disease, especially acute kidney injury, acute renal failure, if the patient had taken any drug, toxic drug, especially painkiller, non-steroidal drug. Jadi tanya, abang, kakak ada makan ubat tak? Tak ada. No drug history. Tapi, bila kita tanya dia makan ubat, kita nak tanya painkiller. Ada tak makan ubat tahan sakit? Tak ada. And you think that's enough? No. You will not get history dia makan ubat sebab you tak tanya dia ada tak sakit kepala, dia ada tak sakit senggugup, dia ada tak sakit sendi. Kalau orang tu dah selalu sakit sendi, you tengok gaut dia bengkak. Orang tengah kata bengkak cobong. Takkanlah dia bengkak saja sakit, dia tak makan apa, dia duduk sandar, dia tengok TV je, dia mesti makan ubat tahan sakit. Dysmenorrhea tiap bulan 2-3 hari MC, 2-3 hari MC. Takkanlah duduk kat rumah dia ambil MC, mengadu, menangis gitu je. Takkan makan painkiller. Migraine dah bertahun-tahun sakit. Ada visual effect lah macam-macam. Takkanlah tahan gitu je. Lagi tahan, lagi kuat iman, lagi banyak pahala. Mesti makan ubat painkiller. So tanya dia, do you have any chronic pain? Do you have any joint pain? Do you have any headache? Ya ada. Bila ada buat apa? Ada ambil ubat nak kurangkan sakit? Ada. Baru ada history. That depend on how you take the history. Right? So drug can cause drug injury, drug-induced fever. So the way you take the history itu is depend on your knowledge about the differential diagnosis. When you know that there are potential differential diagnosis, you ask the right question to get to that possibility. Kalau dia tak ada benda tu, you tak payahlah check ESR ke, antinuclear factor ke, TB sputum ke. Tak payahlah sebab that's unlikely. Right? So, what you examine the patient and investigate subsequently depend on your history. History is very important. History of current presenting illness, history, past history, especially surgery, the admission before, transfusion before, alright? Some of the diseases may have history years before. Blood transfusion, sekarang baru detect hepatitis C, hepatitis B. Marriage, memang dia kahwin sekarang, tapi sebelum dia kahwin sekarang, dia dah kahwin 2 kali dulu cerai. Yang kahwin yang suami dulu kat Singapura, kerja apa tak tahu. Sekarang ni dia dah seroconversion to HIV. You need to get good history. Kalau tidak, diagnose HIV je tapi nak buat contact tracing macam mana? So it's important. Habis masa. So I'm sorry to start with sorry and I have to say sorry at the end because I didn't have the slide because of technical communication problem. Tapi for you, this session, I'm sure the organizer is not meant to make this session as intimidating, threatening experience. It's just to share information as much as possible. Obviously, one day we're not going to pretend that you learn everything. But in the process, you've got questions to ask, you've got things to discuss. You do talk, you do ask. And I'm sure you can take some of the email, you can communicate subsequently. Alright? But whatever you build up from here, you know that you got a long way to go. And even you secured this housemanship already for 2 years, remember there were 20 to 30% fatality every year. And you want not to repeat that because not only it's not fair to you, to your parents, to the sponsor that have paid hundreds of thousands if not million, but also not fair to those queuing to get the post. Sian kat dia, orang tak boleh masuk. So you need to do well. You need to do well. And for those who had come to this program, I'm sure they had to be the best lah. Alright? So apa-apa yang betul daripada saya, apa yang betul daripada Allah SWT, yang tak betul daripada saya sendiri, saya sudahi dengan wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. All the best to you.
Terima kasih Dr. Ghazali. Dijemput Dr. Azwan untuk menyampaikan sedikit cenderahati kepada Dr. Ghazali. Persilakan. Oh, ada siapa yang mempunyai soalan untuk bertanyakan kepada Dr. Ghazali? Oh, ada. Assalamualaikum. Nama saya Sofia, grad dari Ain Shams University Egypt. Nak tanya apa yang superior, apa yang MO specialist expect daripada houseman during medical posting.
Okay.
Terima kasih.
As I said, houseman is the frontliner. So obviously you had to do the usual thing lah, take history, examination, and then come up with a diagnosis and differential diagnosis. And then from there you plan care, sama ada investigation, treatment. Right? You cannot spend 3, 4, 5 pages of clerking, history, complaint, physical, history presenting complaint, past history, sampai ke bawah, tapi tak ada diagnosis. Macam mana gitu? You have to have a diagnosis. Tapi because it is not clear yet, you have to have a set of differential diagnosis. Sakit perut, what are differential diagnosis? Rupture aneurysm ke, peritonitis ke, pancreatitis ke, fatty ulcer disease ke, you have to have that differential diagnosis. And then based on the differential diagnosis, you run few set of planned investigation. Ultrasound, plain X-ray, blood test, liver function test, renal profile ke, blood count ke, right? Urine examination ke, you janganlah buat semua, right? And then you need to have a preliminary management. Patient tu muntah,
You probably had to, have observation how many vomit chart berapa kali dia muntah, lepas tu you had to do something for the vomiting. Give MSC agent ke, ataupun put nearby mouth ke, ataupun patient abdomen distended ke, put rice tube ke, because bau sound dia selagi. So you had to have that early preliminary management. Sama ada nak refer to gastroenterology for ERCP, for biliary stent insertion ke apa, that one later on. But at least had that. Lepas tu your medical officer can, okay, what's this guy's problem? That's another thing. You do the clerking, you need to know as much as possible, but you cannot be writing everything there. Especially if you're working in electronic hospital, you tahu kan, duduk kat keyboard nak tulis tak situ. Komputer slow, lepas tu tengah-tengah complete tulis, patient collect, lepas tu telefon bunyi. So you cannot be writing pages and pages on computer. So you have to learn to write succinctly, keying in important part of the history and examination. Tapi the rest tu you need to have some information in your brain or something scribble. Lepas tu you present to the MO. But the MO also has to go to many places. So you cannot be standing there half an hour to present the case. When he does the business round, you have to say, this is a 53-year-old diabetic, retired teacher, presenting today with today's history of abdominal pain. Yang lain tu past history dia ada 15 anak, 14 cucu. Itu kemudian. Faham tak? Because okay, this case is what? This is a guy with chest pain, with cough, pleuritic pain, pleuritic cough, and productive cough of yellow sputum, and temperature 9 degrees Celsius. Physical examination showed slight changes suggestive of pneumonia on the left bed of the lung. Okay, so what's your plan? Have you looked into the possibility that this is coronary artery disease? Yeah, I checked for ECG nothing. That's business around. Okay? Tapi kalau you tak boleh buat, dia tanya je. Tanya. That's part of the learning process. Lepas tu marilah specialist. Pula. Specialist tu, hopefully the MO will guide you ataupun MO present. You duduk senyap dia tu. Tapi specialist also want to evaluate you to decide whether you pass or not. Jadi mungkin for 20 cases that you handle, 10 cases, one case tu dia ask you to present fully. Faham tak? Right? Is that okay? Kerja lain-lain, ambil darah, pergi lari sana, pergi minta request tu, minta ultrasound cepat sikit. Macam semalam saya nak buat CT scan untuk patient sakit kepala, takut ada hemorrhage ke apa. Fill out the form, tapi MO go round, kalau sebab MO tak ada dalam nephrology. Kalau ada asthma, harus semua pergi untuk explain, why you need to give the appointment urgently, that sort of thing lah. So that part tu is art of communication. Number two, because kita tak ada staff lain untuk lari, so you berlari. Tapi kalau kita hantar attendant pun, attendant tak boleh nak cerita why you must give urgent. You must be a doctor. The doctor in this case is houseman lah. Okay. Itu yang medicine, yang lain-lain, yang ONG, Salim, delivery, itu nanti tak tahu siapa yang cerita pun dah. Orthopedic nak masuk POP ke, nak buat traction ke apa, itu cerita dia orang lah pula. Okay, is that right?